Oh, talking to myself. Hello, everyone. We're going to get started in just a minute. Hello, Cynthia, Margaret. How are you? Feel free to put any questions or comments into the QA or the chat. I'll be looking for both of those while I'm presenting. And Tony, I'll bring you up to panelist for your portion. Hi, Tony. Glad you can make it. All right. Hope everyone's having a good week. All right, Medicare 101. Please feel free to ask me questions. It's going to be fairly detailed, so I'd encourage note-taking, or if you want to take pictures of any of the slides with your phone or on your computer, feel free to do that. I'm happy to share any of my information. Yes, Tony, I will move you to presenter during that section of the presentation. Hi, Bonnie. Nice to see you this evening. I was just saying, if you have any questions, feel free to put them in the Q&A or in the chat. I'm going to put my phone on silent, and I'd encourage you to do the same. I'm going to go ahead and get started because it is being recorded. Feel free to add any questions as we go along. It's pretty detailed information, so we're going to get right into it. I wanted to start with a cute picture of my kids. It's a couple years old, but I think it's really cute. It's probably the best, makes Evie look really well behaved holding her hands like that. I'm Abby. If I don't know you personally, I know most of the people on the webinar. This is my husband, Tom. We're a husband and wife team that works on retirement planning, planning for the next 20, 30, 40 years of your life. And how do we do that? And what are the different factors? So one of the reasons we're coming this evening with Medicare, and I'm doing it solo this evening, but one of the reasons we're talking about Medicare and long-term care and healthcare needs in general is because it is such a big concern moving into retirement. How do we plan for that? How do we know how much to save? And how really does the system work, right? Because if you know anything about Medicare, you know that it's a combination of a government program and private insurance, right? And so there's a combination of both, and sometimes there's miscommunication. How do the two things work together? So we're going to explore some of that this evening. And then Tony's here, which I'm so glad she's here, helping me out this evening. At the end, we're going to talk a little bit about long-term care and how do we plan for that eventuality as well. So here's a brief outline of what we're going to go over. Enrollment for Medicare, what's original Medicare, so what's provided by the government, what's an advantage plan, a supplemental plan, prescription drug coverage, and then how does this overall coverage fit into your retirement plan. I'm used to giving this in person and not over a webinar. So there's actually a workbook that I normally hand out at this time where people can fill in answers. So there is some detailed information for the purpose of the workbook for people to take notes. So that's why I think it'd be perfect if you wanted to take notes. I have updated all the numbers for 2021, so it should be, right on track. Paradigm Money Management is my company. We're a registered investment advisor, so we're independent advisors. We're not hooked in with any of the large firms. I explain it as, we're a boutique firm. We get to choose which insurance companies, which products, which services make the most sense for our clients, instead of being told that by, a chief investment officer, chief executive officer at one of the larger companies. That means we're, brokers on the insurance side. And on the money management side, we get to choose from a variety of experts. So this evening, we're not going to talk about any, risk or loss of principal. We're really focusing on Medicare. Okay, so most of our retirement clients are concerned about some of these key issues. Number one, we're afraid of missing important deadlines, right? Because there are some deadlines with how you file and how you communicate with the Medicare office or the Social Security office. We're going to talk about that. There's a fear of making a mistake when it comes to coverage, and there are some key things we're going to cover specifically on that, where if you don't, for example, use a benefit, you lose it, or if you don't have the opportunity to apply, it might not come again. So those are some things we're going to consider. Buying too much coverage or not enough, right? That's always the concern with insurance. We don't want to feel like we're wasting money and buying more coverage than we need. And we also don't want to get stuck with a really large bill if we don't get enough coverage. We see a lot of clients that are getting overwhelmed by the options and relying on original Medicare alone, instead of finding a private option to supplement perhaps, or looking at Advantage plans. So and then finally, the overall increasing priority that healthcare becomes in retirement. So instead of going from a group plan, now we really have to change gears and focus on what an individual plan might mean, how you might need coverage that's different from somebody else. So working with someone who's a broker and can help you see through some of those options can really start to be very important. Okay. Well, there's lots more people here this evening. I hope you heard some of my intro. Thanks for joining us. If you have any questions, comments, feel free to put them in the chat and I'll be happy to cover. Feel free to take pictures of any slides if you want some of those details. Welcome. We're just getting started, so good timing. Okay, so how much do retirees spend on healthcare? This is an article from 2019, so it's not totally updated, but as you can probably anticipate, most of our expenses have gone up and not down, especially through the pandemic. So, when you're preparing for retirement, healthcare expenses are probably one of the last things on your mind, because the biggest concern is how are we investing our money and how are we receiving income in retirement? But retirees can end up spending tens or even hundreds of thousands of dollars on healthcare alone. The average retiree spends $4,300 per year on out-of-pocket healthcare costs, according to a study, and that does not include long-term care. So this evening, we are going to discuss long-term care towards the end, just so you can be prepared for what some of those options are, and situations that Tony, who's also on the call, and I have experienced. Medicare will help cover some costs, but coverage is far from free. So we're going to cover all that information today. Okay, here we go. I'm actually going to skip this slide and just go right into the information if you don't mind. All right, so when do you sign up for Medicare? There's really 3 different enrollment periods to keep in mind. One is the initial enrollment period, then there's a general enrollment period and a special enrollment period. An initial enrollment period is at the very first date that you qualify, right? So turning 65 would be that initial enrollment period. The general enrollment period comes around every year. So on an annual basis, you're re-renewing. Is this everything that I want to do? Excuse me. And in particular, this is for Advantage plans, which again, we'll cover in a little bit. And then special enrollment periods are really for those people who are working. So you have a group plan provided by your work or through your spouse's work. And when you quit from that job, let's say you don't quit until you're 67, that's when a special enrollment period would be, for you as well. Okay. Because we're going to cover it in a little bit, but you can keep your group plan from your employer until you decide to be done working and then apply for Medicare. You don't have to do it at 65. Okay, so how do you sign up for Medicare? It happens automatically. You're enrolled when you start collecting Social Security. So if you've already been through that process, enrollment in Medicare is automatic. And your card arrives in the mail about 3 or 4 months before your 65th birthday. So there's a window of 3 or 4 months before your 65th birthday where they're giving you a set amount of time before your initial enrollment period to look at your options. All right, I'm just keeping my eyes open for the chat or for the Q&A. Oh my goodness. Okay, how do you sign up for Medicare? So if you're not collecting Social Security, we need to look at your initial enrollment period, which is 100 days before your birth month. So even if you're, June 29th or June 30th, for example, it's still 100 days before June 1st, 100 days before the birth month. And you can enroll in two different ways. You can either call your Social Security office to schedule an appointment, which I would suggest going through the process the first time. They're pretty easy to get an appointment through. Or you can sign up at medicare.gov and then you're going through the process yourself. I've seen a couple of people do this incorrectly. For example, if you're 65 or 66 and you're still working, you do need to sign up for Medicare Part A. There's no premium on that, but it is a benefit that you'd have on top of your group. And I've seen people go into medicare.gov and sign up for A and B. Now the premium's coming out and they have to pay a fee every month, and you don't need to pay that fee. So I would call and encourage you to schedule an appointment if it's your first time handling that for your family. Okay, so this is what your Medicare card looks like, pretty straightforward. It shows you, Part A and Part B here and when the coverage starts. These dates are the same because in this example, this person's not working. So their coverage for both A and B started at the same time. But it could be different dates depending on when it initially started. And then Medicare number used to be a Social Security number. Now, of course, it's not for privacy reasons and protection. All right, I wanted to go a little bit into, I like, understanding the history of how things work so we can see, how this program is going to be for the long term. If you're relying on Medicare, Tony and I have this in common. I have a 101-year-old grandma. I think her grandma was 100 when she passed. And she's been in retirement for 40 years. 40 years. She retired at 60 from the public school system in California. And if you're going to rely on a government benefit for 40 years, providing such an important benefit to your retirement, I think it's very helpful to understand the history to make sure we know the longevity of these programs, right? Okay, so this was part of the 1965 Title 18 of Social Security Act to provide health insurance to people age 65 and older, regardless of income or medical history. So the way that you qualify, just to review, the way that you qualify for Medicare is by being somebody who's worked 40 quarters, which is 10 years. So 40, 4 quarters in 1 year, 40 quarters. If you've worked 40 quarters in your life or you're married to someone who has done that, you automatically qualify for Medicare to receive original Medicare from the government. If you do not qualify, maybe someone immigrated here at 50 and they don't have the 40 quarters, for example, then they would be paying a premium even for Part A. But if you have those 40 quarters, you can get Part A for free. All right, so let's cover some terms. These are, common health insurance terms, but I want to make sure we all have the same kind of language when we're talking about this. So premium, so this is what's paid per month or per year to purchase the policy. So when we're talking about insurance and we say this is a premium to pay for the insurance, like your car insurance, the premium is the monthly amount for your car insurance, right? This amount could vary for Medicare in particular based on what company you use, how old you are, where you're located. Medicare is actually calculated based on zip code. So depending on your zip code and how many other people your age are using the services, how sick they are in your zip code, it could definitely change your premium amount. Deductible, this is the amount the insured, so you, the family, the owner of the policy, is required to pay out of pocket before the coverage begins. So this is, might be $400, $500, $1,500, the amount that you have to pay before your insurance kicks in. This really reduces the premium amount in particular. Copay is a designated amount the insured is required to pay for specified services. So you're probably familiar with this from a group plan, perhaps. Going to the hospital is $150 out of pocket, no matter what service or how long you stay. That's the initial payment that comes out of pocket right away. Coinsurance, indicating that the expense will be shared between the insurance provider or the insured. So coinsurance would be 50-50, 80-20, 90-10, and it's describing the split of what percentage you're going to pay and what percentage the insurance company is going to pay. Okay, out-of-pocket maximum. This is the amount that the insured would pay in 1 year for covered or in-network services, prescriptions, etc. There's no out-of-pocket max for out-of-network or non-covered services or prescriptions. So what that means is when they say out-of-pocket max, they really mean for the things that we cover, for the things that we decide we're going to cover, or the doctors or the services or the hospitals, what's the maximum amount that we would require the owner of the insurance policy to pay in 1 year. And once you hit that amount, now insurance is going to kick in 100% for everything in network. If it's out of network, it doesn't count towards your out-of-pocket max. So that amount could be infinity. They're not going to count it towards your out-of-pocket max at all. Catastrophic coverage. This indicates another level of service determined by the amount the insured has already paid out of pocket for the event or the year. So it's similar to out-of-pocket max. This is a fairly large amount that would come out of the insured's pocket. And now we're into the catastrophic coverage category. This is in particular with prescriptions. And now here's another level that the insurance company is going to kick in. So before catastrophic coverage, you might be splitting 50-50 for any service. After you hit the catastrophic coverage mark, now it might be 90-10 that the insurance company covers 90%. So we'll see an example of that in just a minute. I hope those terms help make sense, make sure we're all talking on a level playing field, right? Okay, so let's start with making sure we all understand original Medicare. When I say original Medicare, that means the Medicare that's provided by the government. What are the plans that the government is providing? So this is Part A and Part B. That's what's covered by the government. So Part A really covers hospital care. That's a big focus of Part A. It's premium free if you qualify for Social Security. So again, if you're working those 40 quarters or you're married to someone who worked those 40 quarters, you qualify for Part A without paying a monthly premium for your coverage. When you're in the hospital, the first 60 days are covered at 100%. And if you need skilled nursing, the first 20 days are covered at 100%. We're going to cover all this in a little bit more detail, but this is a general overview. And there's a $1,484 deductible per occurrence. So per occurrence means if I'm in the hospital for 13 consecutive days, 13 days in a row, I'm paying $1,484 at the beginning of those 13 days. And then the rest, my total 13 days is covered because it's within the 60-day guideline. If I come home and I go back to the hospital 2 months later, that's a separate occurrence and I'm paying another deductible for that. So keep that in mind when it comes to occurrences. So I hope this link works because I wanted to show you, let me see if I'm sharing the right screen. Okay, so excuse all my tabs up there, I'm sorry. But I wanted to show you, this is a great link on the Medicare.gov website. I would write this down for sure. It's medicare.gov/coverage. And this is a government website where you can see, is my test item service, is it covered by original Medicare? And you can just type in whatever test item or service you have here and click go. And it's going to give you a pretty clear yes or no answer. So that's something that I do appreciate about the Medicare system is they do have clear yeses and nos for a lot of tests and providers and services. And so you can find that there, medicare.gov/coverage. It's going to look at Part A and Part B to see if that is covered. Okay, so let's talk about Part B. Part B is medical services. So we're looking at outside the hospital. So we're looking at going for our preventative care, looking for colonoscopies and mammograms and all those kinds of doctor visits, lab work, x-rays, ambulance, emergency room, outpatient surgery, all those things that happen outside of the hospital are covered under Part B. Actually, the doctor visit that happens inside the hospital is still considered Part B. Part A covers the room you're actually staying in with the bed and the services that you receive there, but the doctor coming to visit you inside the hospital counts under Part B. Very specific, I know, but it's pretty black and white. For Part B, you will be paying a monthly premium. And if you're receiving Social Security, this will be coming out of your Social Security benefit. So it's $148.50. There's a little asterisk there because that amount goes up every year. Last year it was $144 and change. Now it's $148 and change. So that amount is going up on a yearly basis. The other part of B that makes it distinct is you're in an 80-20 plan with the government. So Medicare is paying the 80%. They're covering 80% of the services, whatever the doctor charges, that's going to go to the government first. The government's going to pay 80%, and the 20% is going to come to you to pay. There's also a $203 annual deductible. So before the government pays their 80%, they're expecting you to pay $203. Then their 80% kicks in, then you pay the rest with your 20%. Okay, so those are Part B medical services. That's what the government provides, Part A and Part B. And that's the current payments for that. Okay, so I don't see any questions so far, so I'm going to keep going. But again, feel free to put in questions if you have them. Okay, I'm not sure. I really haven't met very many people this applies for, but I thought I would go over it for just a second. This is income-related monthly adjustment amounts, what's called IRMA. So this is for anyone that doesn't have 40 quarters of coverage. If that's you, I'm not going to read through this paragraph, but if that's you, let me know and I'll help you find your updated calculation for what that is. So these numbers are a little older. I apologize about that, but I think it gives you a good view. This is from 2019. I really like the pictures on this chart. I'm not going to lie. So this is talking about Part B premium. And it does depend on what your income is. I think I have a better chart in a couple slides, but I like this visual here. So the more income that you're making, the higher your Part B premium is. So that 148 should be in this box at the initial lowest amount. That's the lowest amount that you could pay is 148 based on what your income is that you're filing with the IRS. And it increases in these kind of brackets. So your Part B premium could be significantly higher. If you're interested in these numbers, I'll follow up an email since these aren't the updated amounts, but it's also very easy to find. Okay. When you delay Part B. So if you remember me saying when you're 65, you have to enroll in Part A, even if you're currently employed and you're part of a different plan, or maybe you're a vet or married to a vet and you have TRICARE or VA services, you still want to enroll in Medicare Part A. Part B, you have the option to delay. And here are some reasons why. So if you're working and you're covered under an employer group health plan, or you're covered under a spouse's employer group health plan, you will have no penalties and no loss of options if you delay Part B. All right, I saw Cynthia's question. That's why I'm pausing. So yeah, Cynthia, retired military. So we have TRICARE. How will Medicare affect us? So that's a great question. Initially, the biggest thing that you do not want to delay is applying for Medicare Part A. So that still needs to happen at 65 in that initial enrollment window when you're 100 days before your birth month. That's really when you need to engage Medicare Part A. Part B, is probably not necessary. TRICARE is such a great coverage. So yeah, that's how you would handle that. I hope that's helpful. Okay, so retiree or union plan. So there are some, these are becoming less and less of an option because companies really can't afford to provide health insurance long-term for their past employees. But if this applies to you, I'd love to have, for you to have the information. So retiree or union plans, there's a couple questions you might want to ask yourself, because really at this point you have the option between these kinds of plans, the retiree and union plan, and the full Medicare coverage, because you could delay or you could not. So here's some questions that I thought you would be helpful in asking yourself. Do I go with my retiree or union plan, or do I go with Medicare? First of all, are there copays and deductibles? Does it include a drug plan? If I opt out, can I opt back in later? Do I have the option to return back to a plan if I'm not happy with something else? Of course, what's the overall cost, and does it include dental and vision coverage? So if we're evaluating the difference and the comparison between these two plans and what's going to be great long-term, these are some great questions to start. Just a note that I put here on the bottom, retiree coverage is not credible coverage if delaying enrollment into Medicare Part B. It's not a reason to delay Part B. So if you're a part of a retiree plan from your employer, you still need to file for Part B. All right, so if you can't tell, this is where the workbooks came in handy when I was doing in-person Medicare workshops. And now that we're online, you don't have a workbook, but I thought it might be easy to take a picture of this with your phone or take some notes, whatever works the best for you. But here's all the details about some of the costs and expenses for original Medicare. So we're still talking about the government plan. We haven't started talking about the private offerings for Medicare, but I want you to have all the details to plan accordingly. So this is just for A, like we talked about before, A covers the hospital. So actually staying in the hospital. How much does your bed cost? How much does it cost for them to bring you food and for a nurse to check up on you? That's really what the hospital is covering. So Part A is premium free, right? As long as you have those 40 quarters, you're not paying a monthly payment to get Medicare Part A. There's a $1,484 deductible, which has to be paid up front before any of A can kick in for you. The first 60 days are totally covered by Part A. You're not going to be paying for those days. After the 60th day, now it's $371 a day. That's how much you're paying to stay in a hospital. So I'm sure you can imagine the cost per day is much more expensive than that, but your portion of the cost is $371, and that amount changes every year. They basically increase that amount every year, as you can imagine. Overall, you have 90 days per benefit period. So once you go over 90 days, a benefit period is a year. So if you go over 90 days, now you're looking at your lifetime reserve days. I should have put that in this chart, but once you're over 90 days per benefit period per year, now you're looking at $742 a day. After your lifetime reserve days essentially dry up, you're paying for your hospital stay out of pocket. Okay. The next portion of Medicare A, Part A, is skilled nursing. So skilled nursing is very specific. You have to find a service that calls themselves skilled nursing. If it's not called skilled nursing and they don't bill it correctly, it's not going to be covered. So the first 20 days, it's free, like we talked about before. It's totally going to be covered by Medicare Part A for the first 20 days of skilled nursing. On the 21st day through the 100th day, now it's $185.50 per day. So up to 100 days. That's what you're getting per benefit period. The last thing that Part A covers is hospice. So hospice is when you are diagnosed with 6 months or less. There's no treatment that's happening here. They're trying to make you feel comfortable for the end of life. So that's what qualifies under hospice. So one of the reasons I put 3 very clear boxes under Part A is because for Part A to cover your service, it has to fall into one of these 3 categories. Only if only if it's a hospital stay, a skilled nursing, or hospice. Those are the 3 things that are in these boxes that are covered by Part A. In hospice, your prescriptions are covered, your doctor's visits are covered, 100% inpatient respite care services. So hospice could be in a center or someone visiting you in your home, but this is strictly to make you feel comfortable at the end of life. Okay, Part B, so Medicare Part B, like we talked about before, this is $148.50 per month, and that's the lowest amount. Depending on your income, you could be paying more than that, and it would come out of your Social Security benefit if you're receiving that. If you're not receiving Social Security yet because you delayed receiving that, then you'd be paying out of pocket for that premium. It has a $203 deductible, so that needs to be paid out of pocket before their 80/20 begins. And this is really, again, Medicare is very specific. This is a government program, so it uses very specific language around Medicare. So really what you're looking for when you go to a doctor's office and you're communicating with your doctor about what's going to be covered, you're talking to their billing department maybe, and you're trying to figure out what's going to be covered and what's not. These are the words that need to be used. Is this going to be covered or allowed under Medicare? Those are the words that need to be used. I know maybe it sounds silly, but as you can imagine, they need to be using that kind of language for the government to decide to pay for it, essentially. So it's covered or allowed versus non-allowed. So this is a non-allowed expense. For example, dental is non-allowed. Hearing is not allowed. Vision is not allowed. So it has to be covered to get the Medicare coverage. Okay, medication is very specific under B, and it's really only for people with specific chronic medical conditions. Prescriptions is actually a totally separate coverage that's covered under private insurance. It's not a government plan. The only way to get your medication covered is for very specific chronic medical conditions. And then the last thing is mental health. So this is covered under B, except for psychiatric hospital inpatient stays, which are covered under A, and you only get 190 days in your lifetime that would be covered under mental health. So Medicare Part B, doctor's visits, outpatients, procedures, surgery, preventative care, ambulance care, those kinds of things are under B, and it all falls into this 80-20. All right, I don't see any other questions, so I'm going to go right along. So that's it. That is what the government provides. That's A and B, original Medicare provided by the government. And here's some things that you don't get with A and B. You don't get dental, vision, prescription drugs, hearing coverage, or long-term care expenses. So we're going to cover prescription drugs next. Prescription drugs sometimes is called Part D. Medicare with their alphabet ordering, I really don't understand. They call it Part D, but it is not a part of original Medicare. Part D means you are getting a private individual coverage that you are paying for individually from an insurance company. There's no prescription drug coverage inside of original Medicare from the government. So prices vary by county depending on the plan. So overall, Maricopa has a price that is very similar at the different prescription providing companies. Late enrollment policies may be imposed. So it is important to you have to have a prescription drug plan. It's just not provided by original Medicare. It's not provided by the government, but you have to have it. So there's going to be late enrollment penalties if you do not enroll in Part D. And remember, if you have a group plan at your work or your spouse has a group plan, you don't need Part D because it's covered in your group plan. Most prescriptions are in group plans. But if you're not in a group plan and you have A and B from the government, you have to have D. So don't delay it. And then hopefully this helps you with your question, Cynthia. Vets are exempted from the requirements to enroll, but may choose to do so if you want extra coverage, if you have your VA or your TRICARE benefits. Okay, so here's some examples for individuals or couples who are making less than these amounts. You could apply for extra help with prescription coverage. So the government does not provide prescription coverage as a part of original Medicare, but there is a low income subsidy. So if you're someone that has that, I would ask the Medicare broker that you talk to immediately about that kind of coverage. Part D, companies carrying prescription drug plans may charge a monthly premium for their plan. The amount of the premium can vary. If your income is high enough, you might also have to pay Medicare an amount in addition to your monthly premium. This extra payment is a Part D income-related monthly adjustment amount. So similar to that chart that we looked at with the higher income brackets paying a little bit more, that's really what they're getting at here. Okay, so I'm not sure if you've heard this before. If you've been in one of my workshops, I'm sure you have, but the government actually runs 2 years behind. I know you're probably not too surprised at that. So when you're looking at what to pay in 2021, the government is looking at what you made in 2019. So when they're calculating your Social Security benefit, they're calculating your Medicare benefit, they're calculating your premiums, they're looking at 2019 for that amount to decide what you're going to pay in 2021. Okay, so I hope that makes sense. So next year, they're going to look at 2020 for 2022, right? They're always 2 years behind. So here's, if you want to take a picture of this again with your phone, feel free. It's pretty easy to find online, but you're looking at, how much the Part B payments are here. Okay. So copayment and coinsurance for Part D. I'm not going to go through this exactly because I think this example is better. But there are a couple things to think through. Maybe you've heard of the donut hole. I don't know if anyone's heard of that before when it comes to prescription drug coverage, but the reason they call it that is there's an entry amount here at the bottom. There's a hole with a different amount, and then another amount comes up for catastrophic coverage. It's not the best example, but maybe it's a sandwich. I like that a little bit better. But anyways, when you have Part D coverage, there's lots of different insurance companies that offer Part D. Most of the health insurance providers that you know of probably have a Part D coverage. They are very similar between the different companies. And this is really the structure of how they all are, right? Because they need to operate. The government decides the structure of how these plans operate. And then there's a little variation in price for a couple reasons at insurance companies that we'll talk about a little bit later. But overall, they have this very similar structure. So no matter what private insurance company you receive Part D from, they're all going to operate in this very similar way. But the pricing is going to vary a little bit based on how much coverage and increasing coverage that might vary between the companies. Okay, so the initial deductible is $445 per year. So that increases every year, of course. And that's what you need to pay out of pocket for your prescription coverage, no matter what, before any of your Part D even starts to apply. So you can plan in your budget every year that amount is going to be coming out of your budget on an annual basis. On top of what you're paying for Part D. So this is a number that's on top of your premium. Your premium does not count towards your deductible. It's two separate amounts. Okay, then there's initial coverage period up to $4,130 where you cover 25%. So between $445 and $4,130, you're only paying 25% of generic or brand name prescriptions, either or. You're only paying 25%. Then after you hit $6,550, this is where we hit that catastrophic coverage that we mentioned before. This is your out-of-pocket threshold. Now Medicare is going to start to cover 95%. So instead of covering 25% for yourself, now you're only paying 5%. So I hope you can imagine this is a lot of prescription coverage or very expensive prescriptions that you're buying over the year. And so this is really the structure of how our prescription plans are working. So it's something you can plan for if you're someone who is taking quite a few prescriptions. Okay, I knew there'd be a question about that. Good question, Cynthia. Since we're only receiving Part A, will Social Security still be hit for $148 a month? The answer is no. The answer is no. You're only going to be charged the $148 if you are actively receiving Part B. Yeah, good question. Okay, so what counts towards the coverage gap? So the deductible, the coinsurance, and the co-payments count towards the coverage gap. The discount you get on name brand drugs and what you pay in the coverage gap. Your premium does not count, your pharmacy dispensing fee, and paying for drugs that aren't covered. So similar to the website page that I showed you, where you can look at different services and different procedures, and if they're covered by original Medicare, there's another page on Medicare.gov where you can put in what drug coverage you have. Excuse me, it's not on Medicare.gov, it's with your insurance company. So one of the key pieces of advice here, if you're someone who's currently taking medication or could be taking medication in the near future, if you know the actual medication, the name of the medication that you're taking, I would tell the Medicare broker, who's not me. I have a great contact if you don't have a Medicare broker yourself. But it's important to know if your specific health insurance company covers that specific drug. The biggest thing that holds people up with prescription coverage is there might be 4 different blood pressure medications, and your specific health insurance company only covers 2 of the 4 or 1 of the 4. And if you're on a different one, it's not going to be included in the plan. So knowing exactly what drugs you're on before you buy your insurance, or switching insurance companies after you are changing drugs, might really be helpful. So you definitely have that card in your back pocket. The last thing I'm just going to say about that is you can change prescription drug coverage pretty easily. So if you're someone who's already on a drug coverage, or you want to switch drug coverage, don't let it stop you because you're nervous you're going to get denied because you're taking a lot of prescription drugs. You can switch that on a yearly basis during the general enrollment period. Okay. Now, where do you go, right? So there's a couple different options for how you're going to get your full coverage, because I think we recognize from original Medicare Part A that does not cover nearly enough. So we're looking at what are the other options. A and B has a lot of out-of-pocket costs, right? So in order to cover some of the other out-of-pocket costs, these are really the 3 options. Number 1, keep working or stay on your spouse's plan if you can, to get that group health care coverage. The second option is to go with a supplement, which supplements the original Medicare, or to go with an Advantage plan. So we're going to look at these 3 different options here. Okay, so let's talk about supplement plans first. Keeping my eye on the time because it goes quick when I'm talking about this. Okay, so what happens with Medicare Supplement is you are enrolling for Part A and Part B from the government. You're also getting Part D from any insurance company that offers Part D. So A from the government, B from the government, D from a private insurance company. And you're getting a Medicare Supplement plan to cover anything that falls through the cracks. So when we're looking at Part A, and there's that hospital coverage, the daily cost, the skilled nursing costs, even covering blood isn't fully covered in your hospital stay. The 80-20 for Part B, 20% of every doctor visit, 20% of every outpatient, home health care, medical equipment, all those things that are falling through the gaps that you need to pay for, you can buy Medicare Supplement plan to pick up those pieces. So what happens is when you're going to a provider, let's say you're going to a doctor's office for a visit, your doctor first bills the government for Part B, and whatever is left over, they bill to your Medicare Supplement plan. So your supplement plan is your secondary coverage. And just to make it even more confusing, they also use letters to define their plans. So the government has A, B, and D as your 3, mandatory coverages. And your secondary also has A through N as different options for your supplement. So nice and confusing. Different insurance companies offer 9 different, you might hear them called Medigap or Medicare Supplement. They're saying the same thing when they say Medigap or Medicare Supplement. Each lettered policy is standardized. So if you look at A at United Healthcare and Humana and Signal, they're the exact same plan, and they might vary in cost a little bit because of different factors with that specific company. But A is going to offer the same service at each company. B is going to be the same thing at each company, and so on and so forth. Okay. I like the question. I agree, very confusing. I know. Why would you do numbers? Or letters, you could do anything else. Okay, so like I said, they're federally standardized Medigap plans that are in all states in DC. There's 9 plans, A through N, that are offered in most states. Not every plan is offered in every state or at every insurance company. So one insurance company might have A, B, and N, and another company has J, K, L, just depending on what they want to offer. But again, you know that if you look at A and you want A, you can look at Humana, United Healthcare, Cigna, and they're all the same insurance coverage. Okay, so let me, well, no, that's not what I wanted to do at all. Sorry about that. Okay, having technology issues today. Again, if you want to take a picture of this, please feel free. It's a pretty easy chart to find online. Okay, so these are the type of plans. As you can see, it doesn't even go in the right order. There's no E. They got rid of C and F. If you're, if you're eligible before 2020, you can still buy C and F. But if you're not eligible before 2020, you can't. You just ignore that C and F even exists. And these are the plans that are available to all applicants. And as you can see, there's different parts of the plan that are covered. So some of them are going to be more expensive than others because they have more thorough coverage. For example, if you're someone that wants to travel internationally, you need a plan that covers international travel. And if you don't have one of these 4 that are checked, your plan does not travel with you to foreign lands. So that's something to consider there. So there's hospice care, skilled nursing facility, blood. So Part A does not cover the first 3 pints of blood that you need in the hospital, but these plans cover that. So there's a variety here. F used to be the go-to a couple years ago. F is the most thorough coverage. And so it's the priciest, right? Because you're getting, see, every single box is checked on the way down. Oh, yes, Margaret, I'm happy to share these screens, no problem. I wish I could hand you a workbook. If we were in person, I'd be happy to. Okay, so F has the most coverage, is the most thorough coverage, which made it the most expensive. Now G is the next up. So the only thing that it doesn't coverage is that Part B deductible, which is $203 a year. So after you pay the $203 a year, now this plan kicks in full gear. So there's some variety here if you want to get some pricing differences. Like I said, every company doesn't offer every letter, but it's pretty easy to compare G and D and K and L. And there's some out-of-pocket limit amounts here because you're paying a percentage with the co-insurance. So if you have questions about this, it might be better if we have a one-to-one meeting. I'd be more than happy to do that. Let me mark this question answered. I'm going to put my information to make a meeting in the chat because I would be more than happy to answer any of your questions. There you go. And if you don't have I would really encourage you for this portion. There, now it's easy to click on. I would really encourage you for this portion to find a Medicare broker. And a broker is someone that has access to multiple insurance companies, and then they can compare all the pricing for you and find you the best coverage. If you're not talking to a broker, they might only represent one company or 2 companies, and you're really not getting the comparison of the pricing here. Okay, so when is Medicare Supplement the best path? I'm trying to get my eye on time. There's so much information. Okay, so number 1, if you want to budget Medicare medical costs, so a supplement covers almost everything, right? There's very little that falls through the cracks here. So really you're just looking at a monthly premium to get the supplement amount, and it might be easier to budget for that than to have a bunch of cash set aside in case you need to go to the hospital. If you travel and you may need to see a doctor away from home, if you're someone that travels in between states or you want to travel internationally, a supplement plan is probably going to be your best option. If you want to see any doctor or specialist with no referrals, this is a great plan. If they say yes to accepting Medicare, they will also accept your Medicare supplement. Some plans have no copays and no deductibles. So that's a great option. There's not a lot of extra cash that's coming out of your pocket, just the monthly premium amount. And here's the last and final kicker. If you apply for it during your initial enrollment period, you are assured to get it and keep it. So they can't kick you off the plan in future years when you get sicker. But if you do get sicker, you might never get into a Medicare supplement plan. So this is something to look into while you're healthy. If you're not healthy, they don't have to accept you in a plan, because technically the Medicare supplement is your secondary insurance, not your primary, and they don't have to accept you in the plan. So if you're someone who's currently sick and not yet 65 and haven't done the Medicare thing yet, I would consider Medicare supplement. One of my clients had end-stage renal disease, and he got into a Medicare supplement right at 65, and it was the best thing he could have done. It covered almost everything. Okay, the ABCs of Medicare Advantage. So people call this C, to make life a little bit more complicated. So, like we said, original Medicare is A and B, prescription coverage is D. What we're really looking at when you're looking at Medicare Advantage is, instead of going through original Medicare, we're like, nah, we're just going to group all that together and find a Medicare Advantage plan that's going to combine A, B, and D and provide extra benefits. So instead of having original Medicare and a Medicare supplement plan, you only have a Medicare Advantage plan, and everything has to go through that private insurance company. Okay, so you must be enrolled in original Medicare A and B. So you go through the enrollment process, but it still doesn't act as your primary insurance. You enroll and then you buy Medicare Advantage, and then everything defers to your Advantage plan. Premiums vary significantly. You've probably seen some ads with premiums at $0, and that's absolutely true, that you can get a Medicare Advantage plan for $0. And it even pays for Part B. So the Medicare Advantage plan not only is $0, but you don't pay the $148.50 to Part B, because your Advantage plan also pays for Part B. So people love that, of course. And it's based on your deductibles, your out-of-pocket max, your coinsurance. So similar to your group plan, if you're at your employer and they say you can have this plan with a low deductible and a higher premium, or you can have this plan with basically a zero premium and a much higher deductible, that's how Advantage plans also work. Okay, so I'm not going to get too much in the nitty gritty, but there's so many different kinds of Advantage plans. So supplement plans, you can look at Part A at United, Part A at Cigna, Part A at Humana. Medicare Advantage plans don't have any rhyme or rhythm to them. They are so different. They have to offer what A and B offer as original Medicare, but they also offer tons of extra random things that are bells and whistles and services that they've added on to their insurance plan. They could be HMOs, they could be PPOs, they could be private fee for service. They really can create whatever kind of plan they want to. And so there's so much flexibility there, which again is a great reason to work with a broker, because they represent all these different insurance companies and can help you find the right plan that makes sense. Okay, so Part C, like I said, replaces A and B and can include D. So there are some Medicare Advantage plans that have everything A has, everything B has, and everything D has with the prescription coverage. They can be PPO or HMO. There's usually one or more plans available in a county. I mean, we live in Maricopa County, everyone on this phone call, so there are tons of different plans in Maricopa County to look at. And some of them do include an a maximum out-of-pocket max for what you're going to pay. When is Medicare Advantage the best path? Number one, you are definitely paying a lower premium. So like I said, there's some zero premium plans, which is very enticing for people on a limited budget. You can use this as a backup for VA services. So if you're looking for a secondary insurance that's not too expensive to pick up anything that your primary might leave over, this is a good option for that. If you are very attached to your network of doctors, this might be a really good plan, especially Cigna comes to mind, because they have like a local network of doctors that are very close to you. They might even have a car ride service to pick you up and drop you off at your doctor's office. There's some, fancier benefits like that if you're someone that needs that. Or if you're on a low income subsidy for Medicare, this could definitely be the right path. Okay, so an employer plan. So when you are on an employer plan and you're over the age of 65, you still need to apply for original Part A, not B, just Part A. You need to enroll in Part A because that's going to act as your primary insurance. So any claim that you have is going to go through Part A. There's going to be a lot of things that aren't covered, right? Because like colonoscopies, for example, are not covered under Part A. But it's going to go through Part A first as if that's your primary, and then it's going to hit your secondary insurance, which is your employer group plan. This can be yourself or your spouse, PPO, HMO. You could be actively employed or on COBRA. So if you really love your insurance from your group plan and you're not working there anymore, you could still be on COBRA, which at maximum is 18 months. And then after that 18 months, you'll have to fully enroll in Medicare. Okay. So what else needs to be covered? So here's the list we looked at before. Now we're going to head on to long-term care expenses. These are really the expenses at the end of life, not necessarily hospice. We know that hospice is being covered by original Medicare, but this is, you need someone to come in and help you give your medication. You want to move into a nursing home, long-term care facility. This is for at least, 1 to 3 years, paying an increased amount. Really, there's a lot of healthcare expenses that come at the end of life. So give me 1 second. I'm going to bring Tony up. So I think you might have to accept that, Tony. Promoted her to panelist. Hi, Tony. All right, so I'm going to ask you to unmute.
I am unmuted now, and let me start my video again. It took me off. You cannot start your video because the host has stopped it. I'm fine with that. Whatever works. So I can just go ahead and go into my presentation and share my screen. All right. So I'm going to hit some very high level topics about long-term care. Long-term care is not covered under Medicare. Abby mentioned that several times. And I will tell you, Abby mentioned longevity in her family. I've got longevity in my family as well. One grandma just passed at 100 this year. My other grandma lived to be 97. So not only in my 30 years in the industry do I have a lot of professional experience helping people with long-term care, I have that personal experience. So I want to spend about 10 minutes just hitting some highlights about long-term care, and then you can have a more detailed conversation with someone like Abby at another point, or maybe this is even something else to discuss. So, okay, I'm going to go ahead. Abby, you keep me on.
All right, yep, we can.
All right, so you can see long-term care needs. Are you prepared? Yeah. So long-term care means a lot of different things to a lot of different people. I remember when I grew up in a small town, Nebraska, long-term care meant a nursing home. It does not mean a nursing home by any means anymore. There's a lot of different ways to get long-term care. They all have their advantages, and there's also some challenges with each of them. So long-term care, what does it mean? As we live longer, we normally need some extra help towards the end of life. I once had someone ask in a meeting, hey, has anyone here in this room needed long-term care before? And nobody raised their hand. And she said, every one of you has needed long-term care. It was when you were an infant. So many of the things that when we're a baby that we can't do for ourselves are some of the things that as we age are more difficult for us. So it's something as simple as eating, bathing, getting dressed, toileting. I don't know why my build stopped going out here. Mobility and continence. These are just normal things that happen in life to any one of us that lives longer. When you can no longer do 2 of these 6 activities of daily living, that's when long-term care needs and long-term care coverage could kick in. And I will tell you, normally a lot of these things happen all at once. So with both my grandmas, they did really well just the last 2 years of their lives that they needed additional help. The other thing that could define a long-term care need is cognitive impairment. So as we live longer, we have no control over what might happen to us. Dementia, Alzheimer's, those things can come into a family. And many times, again, those activities suddenly come into pair, but also we can't necessarily be left alone safely without some additional care. So right now, I'm going to show you some future estimates for how many people are going to need long-term care in the United States. So right now, it's expected to double from 7 million people that currently need help with some of this to 14 million people needing this by 2065. Because if you're over 90, there's a 50% chance you are going to need help with some of these things. Might be at 90, might be at 95. My other grandma made it to 98. But again, it's going to double from 7 to 14 million. Well, that means we have a whole lot of people competing for the same care. And you definitely want dignified care, and you want choice in your care as you look to what you want for yourself. And here we can see it's a little different for men versus women. I don't know what the makeup of the audience is here, but men need help for an average of 2.3 years, and it costs $142,000. Well, as women, we live longer, so we typically need the care longer, and we have to budget more. And I do a lot of planning with women. And sometimes, you know, we've taken time off to raise our families. We've worked in industries that may have not have traditional pensions. We may have less Social Security to work with, and we're living longer, and we have more expenses. So how are we going to address that? Now, some people will say, hey, don't worry about it. My husband or my wife will take care of me. Or my daughter lives in town, and it typically does fall to a female relative. I discovered that with my grandma. She fell once. The hospice care came, a social worker, to do an interview, and she said, are there any other female members of your family that live in Phoenix? She didn't ask about my brother. She didn't ask about my dad, because historically it is typically a female family member, maybe a daughter, maybe a granddaughter that helps. It's wonderful to be able to have someone come into your house, but I will tell you, with the grandma that stayed at home, there were certain things I simply couldn't do. She only weighed about 85 pounds at the end, and when she fell, if you saw me, I'm a strong farm girl. I ride horses and I lift bales of hay, and I've got 4 kids. I'm pretty strong. I could not lift my 85-year-old grandma up. So some of the things to think about: is it really realistic that your family can take care of you? Because there's certain stress points that come with that. As I'm just moving my screen around here a little bit, the emotional stress of it's really hard to watch mom or dad or somebody you love suddenly go to the point where they're a little frustrated because they can't do everything they wanted. Time, making sure you have the time to do this. I loved spending time with my grandma, and it was an honor to be able to be with her. But there was time that I needed to take away to be able to be there for her. And I eventually brought someone else into the house to take care of it. I mentioned the physical burden and the difficulty of care. I simply wasn't strong enough to do everything. Plus, needs became more skilled. It was one thing for me to help grandma get dressed. It was one thing for me to help grandma eat. But when it came time to things like giving her a proper bathing, making sure her medications were okay, making sure she was taking her medications, I was not set up for that, and I was not as prepared to do that. Certainly, there's health consequences, stress for the caregiver, the financial stress, the cost, and we'll talk a little bit about that. Again, I'm just hitting some very high levels. And then there's the burden of lost earnings. I was thrilled and honored to be able to give back to my grandma like she had always given back to me the entire life. But not everyone has a grandchild living in their home state anymore, in their hometown. So what are some other ways that you can get care? Well, homemaker services, that's paying someone to come into the home. Home health aides, adult daycare, assisted living, nursing home for a semi-private, and nursing home for a private room. You can see here it varies anything from just going to daycare, $20,000 a year, all the way up to $105,000 a year for a private room in a nursing home. I think the secret here is you don't want to feel fiscally frail when you're your most physically frail. So which of these are going to work best for your care? You probably don't know until you get to that point, but you should be planning and should be considering what it is you may be able to afford. Because when I talk about what are some of your options for this, you're going to again see it's not Medicare. So if being able to go to an assisted living facility and be surrounded by some friends, some structures, my grandma, she was at this place called McDowell Village. It was wonderful. She had structured meals, they had activities. If she fell, there was somebody right there. If she needed a prescription, they took her to the doctors. That was important to her. My other grandma wanted to stay at home. So we look here and see what part of your retirement plan is planning for this, just like it's planning for Medicare, and how much might it cost in your state. I will tell you, this is the current cost 2020. These costs exceed the rate of inflation tremendously, at minimum 8%. So depending on what age you are, and I will tell you, people plan at different ages. Ages 50 to 65 is a great time to sit down with somebody like Abby and talk about, well, what is it that I want? because how are you going to pay for this? It's not Medicare. Well, some people think, well, what about Medicaid? Medicaid, you really have to spend down almost everything you have, which is one issue. But guess what? Even bigger, you have no choice. If you're married and they're husband and wife and they both need care at the same time, somebody could be in Peoria and the state could send someone else out to Gold Canyon, 100 miles between the two of them. And guess what? If the kids are trying to visit mom and they're trying to visit dad, well, that's hard. Plus, don't you think mom and dad might do better in the same facility where they have each other to rely on emotionally, have a friendly face? Well, Medicaid, you have no choice of the facility you go to. And if you have to go to the hospital, your bed is not reserved for you. So imagine you do have a place you like. You're comfortable with the staff. You've got a sense of the belonging, the surroundings. You've got some friends. You have to go to the hospital for 10 days, 2 weeks, 5 days. Doesn't matter. They could give away your bed. And now all of a sudden you're starting over. And where do I live? The other thing we talk about choice, I think with the pandemic, people realized where you live in your later years and what kind of care you have is more critical than ever. And people want that choice. Maybe you want to live in a small home that has 6 or 7 residents and not somewhere that has 500 residents. So Medicare is not going to pay for it. Medicaid should be a last resort. You could self-fund it. When we looked at that screen a few screens ago, that's a lot of money. And you don't want to run out of money towards the end, because what if you have a place you love and all of a sudden you run out of money? Now you go to a state facility. Well, a lot of times the family funds it. And I will tell you, there's a couple different ways here. You can wait until you need the care and then have all the kids figure out what they can pitch in. And most families are, if they can, we want to help mom and dad. We want to help the people we love. But your family might not be able to do that, or they may be extended. There may be other issues there. Another way for a family to fund it, though, and I did this with my own mother-in-law. She's got 4 boys. We bought her a long-term care policy. We did it when she was in her 50s, and I said, you know what, Grandma Colleen, we want to do this. This is your gift. We actually did this kind of a Mother's Day thing, and so we want to make sure you're set. And that way, instead of providing skilled care, we're bringing her cookies and we're visiting during the years that she may need this. So it's not Medicare. You don't want it to be Medicaid. If you're going to self-fund it, that's a lot of money. And do you really want your family funding it? And if they are going to help fund it, well, let's be proactive about it. There are such things as long-term care policies. We're not going to go in that to today, but I will tell you, in my years in the industry, long-term care policies have gotten much different than they originally looked 10, 15 years ago. They've gotten pretty expensive. And they've gotten harder to qualify for. And that's because the industry as a general, actuarial wise, didn't realize that people don't give up their long-term care policies. They don't lapse. And all these expenses are going up. So people that budgeted and could afford a long-term care policy in 2000, 2005, they probably had some price increases. So it's not a bad thing to consider, but you have to decide if it's the right thing for you to consider. And then another option is a combo. There's combination policies. Long-term care policy is often use it or lose it. Grandma June that stayed in her house, I didn't charge her. I mean, she had a long-term care policy, but I'm not charging my grandma. I guess she could have paid me, but it didn't cover that anyway. So it was use it or lose it. The long-term care policy she had, she never used. Combo policies, and it could be, I used an example here of a life type policy with a long-term care rider. That is not necessarily use it or lose it. You have a fund, a pool of funds that you could use for this long-term care you are very likely to need, but if you never use it, well, there's funds to leave behind for a legacy. So there's a lot more flexibility there. Plus, there's often flexibility on how you get the money. I can't tell you what's right for you because it depends. That's why you need to schedule time with somebody like Abby. And I will tell you, Abby is someone, I work with a lot of great agents. I've been in the industry forever. I have all these great agents. What I love about Abby and her practice, she is so holistic. And she can coordinate your planning for any part of what it is you want to do. She's going to coordinate that with some other things that you have in mind. So maybe you have someone you're working with already, maybe you don't, but make sure you're working with someone that's holistic. Make sure you're working with someone that's independent, that can look at different options for you, because this is not a one-size-fit-all type planning. And I can't think of a better individual with a better team around her than Abby. So Abby, I know that was really fast. I hit on so many things so quickly, but in the interest of time, I'm going to stop there.
I loved it. I think you covered all the high points. Thank you so much, Tony. All right, well, that is gonna wrap up what our coverage is. You know, these decisions can make a huge impact on your healthcare coverage for a long time. Really, people are spending 20, 30, 40 years in retirement needing healthcare, needing health insurance, and needing coverage and needing long-term care. So starting early with planning for what those decisions are and how we're going to budget around those decisions is really important. And I've seen it affect people's lives. Like the example I shared with you, one of my clients, he came to me and he already had end-stage renal disease and he was already in Medicare Supplement, and it covered almost everything, all the services, all the hospital visits. He was in the hospital almost every other day getting dialysis. It covered almost everything and didn't leave a bill for his wife. There was another client I spoke to who had end-stage renal disease at 70 and did not have a supplement plan before that, tried to get on a supplement plan after he got his diagnosis and was denied, and left his family 6 figures worth of debt. So it is a significant impact on your financial situation, on your family's financial situation, if you're leaving a spouse behind, on their financial situation. So being proactive about your healthcare, I can't ignore it. I'm not a Medicare broker. I'm happy to introduce you to one if you don't know one. I have a phenomenal female insurance provider that I talk to, but starting to look through some of those options is incredibly important. I'm happy to take more questions. Please feel free to schedule time. There's a link in the chat, calendly.com/AbbeyV. It has my schedule there where you can schedule 15 minutes, 30 minutes, an hour, whatever you think is appropriate to discuss your needs and get some of the options. You know, your bill can easily go from a few $100s to millions in retirement over all the healthcare, you know, concerns that you might have. So that's the end of our presentation. I'm going to go back to the question that I saw in the chat. Feel free to hang out and ask any questions, raise your hand, and I'd be happy to have you even speak and join the conversation. What happens if my husband is 66 now and not started Medicare yet, no Social Security started yet? So Julia, I'm assuming, I don't know if he's working or a part of an employer plan, but Medicare Part A does need to be started and applied for, so you don't get any penalties for delaying that portion. But if they're a part of an employer plan or a part of your employer plan to get the rest of the coverage, that's absolutely fine. You can delay Part B. Feel free to schedule a call or a Zoom interview, whatever makes sense, if you have further questions. Sorry, it was more than an hour, but there was so much info and I wanted you to have the full picture of what Medicare is and how it would affect you and long-term care considerations. So thanks so much for all of you sticking with it to the end. I really, really appreciate that. I'd be happy for any feedback on how to make this presentation better. And if you know anyone that you think would really benefit from this information, please let me know. I'd be happy to send them the recording at the very least so they can be educated as well. Thank you, Teresa. Thanks, everybody. I really appreciate your time and I hope you have a wonderful 4th of July if we don't talk before that. Thank you so much, Tony.